Thermalin Incorporated. And Rick, why don't you talk about your company, introduce yourself, tell us what you guys are doing, and about your new treatments for insulin dependency.
Great. Well, Marty, first of all, thank you very much for inviting me to present about Thermalin. So this is a real change from the last presentation, because we're talking about an opportunity for direct investment for people who are looking to have a significant impact on a major scourge in the world, which is diabetes. So what I'd like to talk about is how Thermalin has a plan and a technology that's going to radically change how we treat people with insulin-dependent diabetes. That's type 1 and type 2. So just a high-level summary, Thermalin has put together what I think, and I'm really proud of this team, of deep insulin experts with a goal of creating disruptive therapies to transform the basic economics of the $30 billion annual insulin therapy market. The key to our doing this is our novel stabilized insulin analog. This is a new type of insulin, we call it T1123, that's going to enable innovations in what we call glucose management systems. A good example of a glucose management system is the stamp pump, which is 4 times smaller than any other system that's available or in development today, and only possible because of T1123. We're currently putting together a funding round that will total around 22 million, although we're looking for a closing of around 10 to 13 in the next 6 months or so. We have a major pharma that is signed up to participate in this. The goal of this financing is to get the clinical proof of efficacy, a preclinical demonstration of the stamp pump device itself, a number of partnerships in place that will get us to a key value inflection point in the next 3 years. So that's the high-level summary. Let me now step back and walk you through a little bit more detail. First, let me introduce you to the team. So I'm Rick Berenson. I'm the CEO, co-founder with Mike Weiss. Mike Weiss, who's just down to my left here, is the chairman of biochemistry and molecular biology at Indiana University. He's really considered the world's expert in the structure and function of the insulin molecule. He also is responsible for a number of key innovations in how you make insulin, how you change the way the molecule works in order to get better results. My chief scientific officer is Dodd Michael. Dodd is the former head of insulin biology discovery at Eli Lilly, a metabolic physiologist who's expert in how insulin affects both animals and people. My chief engineer is Dwight Meglin. Dwight is a former Medtronic technical fellow, which means he was vice president level with no reports. When he left Medtronic a couple of years ago, they immediately hired him back as a consultant with no intellectual property restrictions, just to keep access to him because that's how good he is. And then finally, I'll just mention Jim Malone, who, before he retired from Eli Lilly, was the head of clinical development for insulin products and delivery systems. And I suppose I should also throw in John Brooks. John is our chairman. He's the former CEO of Harvard's Diabetes Center, the Joslin Diabetes Center. So I'll just also mention that Mike Weiss, who's got a ton of publications in this area, was awarded the Grotzky Award by Juvenile Diabetes Research. This is their highest award for advances in basic science related to diabetes. So let me first talk about our economic proposition. Diabetes is fundamentally a disease of insufficient. Type 1 diabetes, you don't have any.
I know you won't.
25% of the people.
You're good about those things. Because I got my last flu shot, I think.
Sorry, there's somebody who hasn't muted. And could I bother to ask you to mute, please?
And if I don't know if there'll be a run on it this year. There could be.
Yeah, like there was.
But
I'll keep talking, but it's maybe a little difficult for people to hear. Well, that's better. Thank you very much. So, since diabetes is a disease of insufficient insulin, you would think that the obvious therapy would be to give people supplemental insulin. However, insulin therapy today is a very high burden therapy. You have to get exactly the right dose at exactly the right time. It involves lots of measuring and calculating and so forth, and the consequence is that people just don't adhere well because it's so difficult. This means that they chronically don't have enough insulin, their blood sugar is chronically high, and this leads to all the complications that accounts for 88% of the $800 billion a year cost of caring for people with diabetes. So if we can lower the burden of insulin therapy, we can lower the rate of complications and dramatically lower the cost of caring for these patients. The key to doing this is automating the dosing process. And we're not the first ones to think about this. There are people who are developing smarter pumps and smarter pens and are trying to make the devices easier to use. However, these devices still don't do a great job in calculating the dose correctly. They only last a couple of days. The user has to fill them by hand with insulin, which is actually about half the work involved in taking care of an insulin delivery device each day. And they have to wear a second device called the continuous glucose monitor to measure how high their blood sugar is. Our technology is going to let us get better control with a device that's 25% the size of any other device in development or on the market. And it will last a full 7 days on top of that. It will be filled at the factory with insulin, so no filling by hand. And in the second generation, it will have the glucose monitoring built into it. So just to quickly review our pipeline, the key to enable all of this is T1123, which is our stabilized ultra-rapid acting insulin. I'll talk about that a little bit more in a moment. It has several formulations in the pipeline. One is a regular concentration formulation, and the second is a high concentration formulation. This is the first time insulin has been able to be concentrated to 5 times normal and still be rapid acting, let alone ultra rapid acting, as ours will be. And this formulation C here on the list is what is enabling the stamp pump, which is the second program down at the bottom. We have a couple of other programs in the pipeline, but our focus today is on these 2 programs. Just to put our insulin in context, there are other people, significant companies with rapid-acting insulins on the market. Lilly, Novo Nordisk, and Sanofi all have rapid-acting insulins. Both Lilly and Sanofi have reformulated their insulins recently to make them faster or ultra-rapid-acting. All of our programs will be at least ultra-rapid-acting. Where we differentiate is on stability, for one. Existing insulins are only stable at room temperature for about 30 days. That's what the FDA gives them. Ours will be stable for at least 6 months. Now that's key to enabling the pre-filling of insulin devices, which we'll talk about in a moment. The second differentiation, as I said, is that we're going to be 5 times as concentrated, yet still ultra-rapid acting, the first insulin that's had those characteristics, and that's key to enabling the miniaturization of these devices. So our focus in insulin innovation has been making devices more convenient for patients by getting over the limitations of existing insulins. So let me just give you a little bit of data. First of all, this insulin is dramatically more stable than the existing insulins. And you can see this on the chart on the left. You can see that in the gray, these are all existing commercial insulins, and the most stable in this particular assay is this is an accelerated assay where we really put the insulin to the stability test. It's done at very high temperature, which is over 100 degrees. It's agitated, shaken very vigorously, and in these conditions, these insulins all begin to degrade in between 7 and 16 hours. Our insulins, both formulations in these conditions, last more than a week. So we're at least 10 times as stable against this type of degradation, which is the main degradation path for insulin, than any existing commercialized insulin. The other nice thing about this insulin is that it has a lower rate of what's called cell growth stimulation. So all insulins are what are called growth factors. And this means that they cause cells to divide more frequently. In fact, one of the only insulins that has failed in clinical trials in the past had an enhanced growth factor capacity. Our insulin, it takes 6 times as much to have the same level of growth effect on cells as regular human insulin does. So for people who need to take high doses, this will be a much safer insulin. That's really just a side note to the main value proposition that we have. Now, I mentioned that this is going to be ultra rapid acting, and here's the evidence. We do these studies in pigs because pig skin, which is what the insulin is absorbed out of skin, is very similar in structure to human skin. And in this study, you can see that the absorption rate, the action of our insulin in the green is virtually identical to the action of one of the rapid acting insulins that's just come on the market called Fiasp. So basically the same as Fiasp on speed of absorption, but we have this 6-month stability. And this is important because it allows us to pre-fill existing insulin delivery devices, something that can't be done with existing insulin because they're just not stable enough. If you filled it, the device would be shipped to the pharmacy. When it arrived at the pharmacy, it would say, put in the refrigerator. It comes in a box this big because you're shipping 4 of these devices at once. And the pharmacy says, I have no room in my small refrigerator to put this big box, take it back. So the only way that you can effectively get distribution is with a stabilized insulin. We've been talking to all of the companies that are currently making insulin delivery devices. They're listed over on the right here. Tandem, Medtronic, Insulet, EOFlow, Kalido, Terumo. All of these companies want to be able to pre-fill their devices so that they can sell the insulin and ship the insulin along with the other supplies for their patients, but they can't do it today. With our new insulin, they'll be able to do that. So that's a significant opportunity and a new distribution channel for this regular concentration form of our stabilized insulin. The real differentiator, however, for our insulin is that when you concentrate it 5 times, it's still ultra rapid acting, as you can see on the graph on the left. So what we have is an insulin that's 5 times as concentrated, so you can shrink the reservoir that it goes into in a device by 80%. It's still fast acting, fast enough to make any of the pumps or any of the delivery systems today work as well as they need to, and it's stable. These 3 characteristics are what make the stamp pump device possible. So let me turn to that now. So here's the challenge we're trying to address with stamp pump. Existing insulin delivery devices are just too obtrusive. For people who don't want to advertise the fact that they have diabetes, and that's basically almost everyone except perhaps for Sierra Sanderson here, they don't want to have to wear a pump that has a big device with a tube that goes to an infusion set. The Omnipod from Insulet has made a big difference by getting rid of the tube, but it's still quite large, and you still advertise the fact through this bump that you've got underneath your clothing that you're wearing an insulin delivery system. The stamp pump, however, will be different. It will virtually disappear under clothing, as you can see on the right. Here's what we've designed. It's 75% smaller than an Omnipod with an ultra-low profile. It will come factory filled with 600 units of